Good afternoon, everyone. Thank you for joining us for our breakout session. Um, I would like to get started and we welcome our guests here today. Our session is COVID response. We have two 30-minute sessions that we will have. The first that we're going to go with is the emergency relief efforts to support maternal health and home visiting. And we have our members from Nurse Family Partnership. I'm going to do a quick introduction to Sharon Sprinkle and Ann Peterson. Ann is a senior research analyst for the National Service Office for Nurse Family Partnership and Child First, where she conducts rigorous evaluation of NFP program implementation, outcomes, and innovation to inform continuous program improvement, and is an epidemiologist by training with an international and national maternal and child health experience and a strong background in program evaluation and data analytics. Sharon is the Nurse Consultation Director, Eastern Region for Nurse Family Partnership. As a nursing leader for the organization, she coordinates and supports the nursing practice roles and responsibilities of nurse consultant at the National Service Office in support of NFP's evidence-based maternal and child health focused nursing practice. So it looks like we have a few more people coming joining us to get started. Awesome. So I did want to let everyone know that as during our time together, feel free to chat in any questions that you may have while you hear Ann and Sharon. And if they have time, they will answer questions at the conclusion of their session. And so I'm going to turn it over to Sharon so that you have your time.
Wonderful. Thank you, Kimberly. Ann and I work at the National Service Office for Nurse Family Partnership and Child First. Our organization oversees two evidence-based home visiting programs, Nurse Family Partnership and Child First. Today, we're going to be focused on a few initiatives specific to Nurse Family Partnership. And I may refer to it as Nurse Family Partnership as NFP. Next slide, please. So our objective today is to describe the connection between social determinants like economic security and access to technology and health outcomes. We also want to assess strategies for operationalizing program innovations in times of crisis and evaluate the impact of innovative emergency relief on key client outcomes, including client retention and engagement. Next slide, please. Who are we? Nurse Family Partnership is a national evidence-based nurse home visitation model with over 40 years of experience. We're in 41 states, and our mission is to positively transform the lives of moms, babies, and families. And our vision is a vision in which a future where all children are healthy, families thrive, communities prosper, and a cycle of poverty is broken. Next slide, please. We have three overarching goals, and we achieve our mission and vision by partnering with public health registered nurses with first-time low-income expectant mothers. Our three overarching goals are to improve pregnancy outcomes by helping clients improve prenatal health and by addressing the effects of smoking, alcohol use, illicit drugs on fetal growth, and to assist women in identifying goals and reducing cigarette smoking and other behaviors which have negative consequences on pregnancy outcomes. We also want to improve child health and development by helping parents provide sensitive and competent caregiving. We do this by supporting their knowledge of normal child growth and development and helping to provide sensitive care. And our last goal is to improve parental life course by helping parents develop a vision for their future. Nurses help families facilitate conversations around planning of future children and creating a reproductive plan for themselves as they identify strategies for gaining employment and continuing their education. Next slide, please. So how do we go about delivering this model? It's delivered by specially trained baccalaureate prepared nurses. And our nurses partner with families before they're 28 weeks pregnant and stay with the child up until the child is age 2. Why do we do this before 28 weeks pregnancy? Because remember that first goal I talked about is to improve pregnancy outcomes. We want to get in early to help inform positive health-related behavior. And we stay along with the family up until the child turns age 2 to achieve that second goal of improving child health and development. Now, while we're a home visitation program, our visits occur primarily in the home or at a location that is preferred by the client. We use a client-centered approach to delivering services while capitalizing on strengths and mitigating risks. Next slide, please. So what does our national snapshot look like? As I said, we're in 41 states, the US Virgin Islands, tribal communities, and recently the District of Columbia. Since we've started in 1996, we have served over 340,000 families. And to date, currently we have 38,000 families enrolled, and services are delivered by 2,300 nurses across the nation. Next slide, please. Like most of us, we had to turn challenges into opportunities because of the pandemic. As I said earlier, our program is primarily a home visitation model. However, telehealth has been a part of our model since 2017. In March of 2020, in response to COVID-19 pandemic, Nurse Family Partnership transitioned to 100% telehealth so that we could continue to deliver services. Like many, our families were challenged with inadequate and insufficient resources before the pandemic, and their problems and challenges were amplified as a result of the pandemic. Our response to emergency relief efforts to address the pandemic resulted in cash assistance to families that we coined Funds for Families, or F4F, and Phones for Families, coined P4F. How do we do this? We did that by conducting a national scan to assess financial needs and lack of access to technology. We selected states based on states that showed the lowest drawdown of employment benefits and received the fewest amount of stimulus dollars to determine which states would receive cash assistance. As mentioned earlier, we transitioned to exclusive telehealth, and we identified roughly 10% of Nurse Family Partnership clients lacked access to technology and therefore would have no way of maintaining crucial contact with their Nurse Family Partnership nurses. So our organization, in partnership with Verizon and Action Technologies Group, provided iPhones to over 3,322 families from April 2020 to January 2021 for over 218 network partners across the states that we're in. Our emergency relief efforts to address the pandemic impacts focused on lack of access to technology and economic and social constraints. Next slide, please. Funds for Families and Phones for Families intent was to provide some measure of financial and communication release of hardships imposed by COVID-19. Nurses used their clinical judgment and knowledge to triage families. Funds for Families was a cash assistance initiative conducted in partnership with Up Together, Blue Meridian Partners, which is a philanthropic collective, Nurse Family Partnership National Service Office, as well as our network partners. $2,657,500 benefited over 5,315 families across 78 network partners in 8 states, namely Alabama, Colorado, Florida, South Carolina, Georgia, Louisiana, Tennessee, and Texas. My colleague Ann will share about the overall evaluation and impact of these 2 very vital initiatives. Ann, I'll turn it over to you.
Thanks, Sharon. So I'm going to go over the demographic differences between Funds for Families recipients compared to the NFP population overall. Funds for Families clients were significantly more likely to be non-Hispanic Black, significantly more likely to have a high school education or GED at program intake, more likely to be employed full-time at program intake, and more likely to speak English when compared to the NFP population overall. Funds for Families recipients were significantly less likely to be married and significantly less likely to be homeless at intake when compared to the NFP population overall. As Sharon said, funds were allocated to states that received little federal COVID relief dollars and geographic areas in need. For instance, roughly 20% of the funds were distributed to Texas in response to the breakdown of the power grid in February 2021. The second table on the right shows the demographic differences between Phones for Families recipients compared to the NFP population overall. Phones for Families clients were significantly more likely to be American Indian or Alaska Native and significantly more likely to be homeless at intake when compared to the NFP population overall. Phones for Families recipients were significantly less likely to be married, less likely to have a high school education or GED at intake, less likely to be employed at intake, and less likely to speak English when compared to the NFP population overall. Phones for Families recipients had on average lower incomes when compared to the NFP population overall at intake. Phones were really allocated to the highest risk clients based on individual needs. With regards to income and employment, reporting on income and employment at program intake does not necessarily show the impact of the COVID-19 pandemic on the NFP client network. These results show the change in employment and income from the pre-pandemic period to the pandemic period. These data only represent NFP clients who had a pre-pandemic income and employment recorded, as well as an income and employment status recorded during the pandemic. These data represent Funds for Families recipients only. Roughly 29% of the NFP client network overall had a reduction in income during COVID. During the same time period, the percentage of Funds for Families clients who had a reduction in income during COVID was significantly higher at nearly 32%. 20% of the NFP client network overall reported a reduction in employment during COVID. During the same time period, the percentage of Funds for Families clients who had a reduction in employment was higher at 22%. These data show that families who received funds were those most impacted economically by the pandemic. So the Funds for Families initiative provided emergency monetary relief to clients in states that received little federal COVID relief dollars and states like Texas that experienced additional hardships. The Funds for Families initiative was in no way intended to incentivize clients to increase or maintain engagement with NFP. However, client engagement is a standard outcome that we measure for each program innovation. As such, we've presented those data here. The first set of graphics on the left shows the difference in client engagement between the Funds for Families recipients and the control cohort. We can see that from the date that the Funds for Families recipients received their cash assistance to present day, the Funds for Families cohort completed on average 10.6 visits. This is significantly higher than the control cohort that completed 8.3 visits during the same time frame. Phones for Families, on the other hand, had a very intentional purpose of providing cell phones and free data plans to clients who otherwise would have had no way to maintain contact with their NFP nurse. If the phones and data plans had not been provided to these clients, we would have expected to see a drastic decrease in client engagement overall in this population. In the set of graphics to the right, we can see that clients in the Phones for Families cohort completed an average of 13.8 visits from the time their phones were registered to present. This is significantly higher than the control cohort, which completed on average 12 visits during the same time frame. This slide shows the difference in client retention and graduation rates in the Funds for Families population when compared to the NFP control group. As of August 2021, 71% of Funds for Families recipients were still enrolled in NFP, which is significantly higher than the control group, of which 58% were still enrolled. Of the 29% of Funds for Family recipients who left the program, 59% of those clients graduated from NFP, which is significantly higher than the control group, which had a graduation rate of 39%. Again, the Funds for Families initiative was not intended to incentivize clients to stay enrolled in and graduate from NFP. However, client retention, like engagement, is a standard outcome that NFP measures for each program innovation. As such, we've shown those data here. While there may be a correlation between receipt of funds and retention, that does not necessarily prove causality. For instance, an NFP nurse home visitor may have allocated funds to clients who were more engaged with the program to begin with, and therefore would be more likely to maintain program enrollment to graduation. This slide shows the difference in client retention and graduation rates in the Phones for Families population compared to the control group. As of August 2021, 57% of Phones for Families recipients were still enrolled in NFP, which is significantly higher than the control group, of which 49% were still enrolled. Of the 43% of Phones for Families recipients who left the program, 47% of those have graduated from NFP, which is significantly higher than the control group, of which 39% graduated. As with Funds for Families, the Phones for Families initiative was not intended to incentivize clients to stay enrolled in the program. However, if we had not provided phones and data plans, we would likely have seen a large early client attrition rate in this population. Phones for Families aim to provide clients a crucial resource that would allow them to maintain contact with their nurse. However, if the client chose to leave the program while the Phones for Families initiative was still in progress, they were allowed to keep the phone they were given free of charge. An important aspect of both Phones for Families and Funds for Families was to reach out to the clients who received these resources to find out their perspective about the two initiatives. The Funds for Families survey was sent out via text message to clients who received funds through the Family Independence Initiative. The survey was open from June 13th, 2021 to June 29th, 2021. The survey was available in both English and Spanish. The final response rate was 27% for a total of 882 respondents. The Phones for Families survey was sent via text message to Phones for Families recipients who were still active. The survey was sent to a total of 2,233 clients. The survey was open from December 1st, 2020 to January 4th, 2021. Again, the survey was available in both English and Spanish, and we had a response rate of 38% for a total of 848 responses. So on the Funds for Families survey, the client was asked, how have you been affected by the COVID-19 pandemic? They could select all responses that applies. These are the most frequently cited responses. 47% of clients said their household income was reduced. 37% of clients experienced financial challenges associated with accessing food or essential items. 25% of clients had to stay home from work to take care of kids due to school or daycare closures. 24% lost a job or had work hours reduced involuntarily. 17% contracted COVID-19 or believed they had contracted it. 16% had their health put at risk due to the nature of their job, and 13% had to move or change housing situations. These clients were also asked how they used the $500 that they received through Up Together and NFP. Again, they could select all that applied. Here are the most frequently cited ways that respondents said they used the funds. 67% of clients said they used the funds for food, meals, or groceries. 48% of clients reported using the funds to pay utility bills. 39% reported using the funds for housing or rent. 36% used the fund for childcare costs. 26% reported using the funds for transportation or car payments, and 5% of clients reported using the funds for healthcare costs. So the survey found that 93% of respondents said the $500 provided from Up Together and NFP was very helpful or essential to clients and their families. Here are some quotes that we received from the open-ended section of the survey. So the first quote says, "My twin sons were born during the pandemic, and a day later, the big freeze happened. We had no water for 3 weeks due to several pipes breaking. Paying for so much water to use and bathe in and to get the pipes fixed really put a dent in our savings. When my amazing nurse surprised me, I could not stop crying. It was exactly what we needed to get essential items for my twins." The second quote says, "Honestly, if I didn't get the funds that were provided, I didn't know if we were going to eat." The third quote says, "We were able to breathe knowing we could pay for the things we needed." So with regards to the Phones for Families survey, clients were asked, which of the phone's features have you used since you received your phone from NFP? The most frequently cited features used were using the phone to text with their nurse. 80% of clients reported using this function. 75% of clients used the phone to text with friends or family. 69% of clients use the phone to call or video chat with their nurse. 63% of clients use the phone to call or video chat with family or friends. And 60% of clients use the phone to search the internet for specific information about the COVID pandemic. Clients were also asked, what activities have you conducted with your phone from the NFP program? 73% of clients reported taking pictures of family or friends. 69% of clients reported participating in a telehealth visit with their NFP nurse. 54% of clients reported participating in appointments with other healthcare providers. 53% of clients reported using the calendar app to schedule visits with their NFP nurse. And 51% of clients reported using the phone to find services and resources to support their families. Clients were asked 4 questions. Here is a summary of the results of those questions. 76% of respondents said the phone they received from NFP met their needs very well or extremely well. 90% of respondents said the phone has helped them stay connected with their NFP nurse a lot or a great deal. 83% of respondents said the phone has helped them stay connected with friends or family a lot or a great deal. And 76% of respondents said the phone has been very helpful or essential to get information or services they needed related to the COVID-19 pandemic. Here are some quotes that we received from the open-ended section of the Phones for Families survey. The first quote says, "My son was discharged from the NICU after 11 months. He's on a ventilator and has had a tracheostomy and G-tube. Since he's been released, we have a lot of doctor's appointments. We also communicate a lot with my son's physicians and durable medical equipment company. If I didn't have this phone, I wouldn't be able to communicate effectively with any of his essential entities." The second quote says, "It has helped me to keep track of the COVID virus, thus helping me to protect myself." Finally, the last quote says, "It has helped me tons by communicating with my nurse. She is so resourceful in everything I've needed. It's been great having a phone in case of emergencies." So here are the key takeaways and conclusions from the Phones for Families and Funds for Families program. Phones for Families and Funds for Families were targeted COVID-19 assistance programs. Roughly 20% of the NFP network received assistance through either Funds for Families or Phones for Families. These interventions has had a positive impact on both client engagement and client retention. Clients were generally satisfied with both Funds for Families and Phones for Families. And finally, partnerships were essential to delivering these supports for on-the-ground interventions for our clients. We'd like to give a huge thank you to the Nurse Family Partnerships partners that made these relief efforts possible. For the Phones for Families, Verizon and Action Technology groups were instrumental. And then for Funds for Families, Up Together, formerly known as the Families Independence Initiative, Blue Meridian Partners, and for both initiatives, the NFP network across the 40 states have been absolutely amazing through this difficult time. And that is all we have. Our emails are listed here if you would like to email us, and we'd be happy to take any questions you might have about these programs.
And you actually do have 2 questions. We have a few minutes for those questions. The first question was, why this shorter time frame for the Fund for Families versus the Phones for Families?
So Annie, I'll take that if that's okay.
Yep.
With the cash assistance program, Funds for Family, it was really important that we get those funds to families as soon as possible. So we had the infrastructure and technology to be able to accelerate families getting those funds.
Thank you. The next question is there data that tracks the birth outcomes of the Funds for Family and the Phones for Family cohorts as compared to control groups?
So we've been keeping an eye on not just the birth outcomes for the different cohorts, but for our NFP network overall. It's a little bit too soon to know all of the birth outcomes as these interventions. Funds for Families, our last funds went out recently. So a lot of those individuals haven't had the birth outcomes yet. And we still have individuals enrolled in the program. So we're still looking at not only the birth outcomes, but the long-term outcomes as well.
And what I would add is it's the nursing intervention that really impacts and supports birth outcomes. While these initiatives were crucial during the pandemic, it's the way the model is delivered and operated that gets us to the outcomes that we have. There was one other question that went with that first question, and Anna, I'm gonna lean into you to answer the question. The person said, I'm sorry, I pressed send too quickly. The person meant to add, why was the time frame for survey responses for Funds for Family participants about 2 weeks versus Phones for Families, which was about 2 months? So why the difference in the length of the survey between the two?
So we, like I said, the last batch of funds were distributed relatively recently, and we wanted to get those responses from all of the participants in Funds for Families. So we sent out the survey and it was only open for a couple of weeks because we had this presentation, and we also sent out several reminders for that survey, and the response rate didn't really increase. So we went ahead and closed it after the 2-week period. Phones for Families was open for a little bit longer because we were still enrolling folks in that intervention. So they could still receive phones through January. So that's why that one was open for a little bit longer.
Wonderful, thank you. And will the PowerPoint be available?
Yes, we'll go ahead and share it.
Awesome. Well, thank you all for your time. We have time for one more question if anybody else has questions. If not, we will transition to our next presenter. And we are going to, thank you. Lynn is our next presenter. The Centering Pregnancy Telehealth Group Care Model and its guidance for adapting in-person prenatal groups to a virtual group. Lynn is the Director of Innovation for Centering Healthcare Institute and responsible for development of products, services, and training tools that support clinicians in applying the centering model of group care across the life cycle. During 2020, the pandemic crisis, she developed tools and led trainings to facilitate centering sites, moving their in-person groups to a virtual format. Prior to her role at CHI, she worked for Clinical Family Health for 28 years as a behavioral health clinic manager, focusing on behavioral health integration on the medical teams. She brought the centering model of group care to Clinica in 2005 and co-facilitated with medical providers, pregnancy, parenting, and chronic pain centering group medical visits for over 13 years. From 2007 to 2018, she was an in-house centering trainer in Clinica, as well as a part-time consultant for CHI training sites across the country on the centering model of group care. Other work experience include 25 years of Lamaze childbirth educator at local hospitals and birth centers, psychotherapy, private practice, mediator, adjunct profession, providing graduate social work students, part-time faculty at social work, graduate school, and clinical social worker with the Lutheran Services. She works remote from Boulder, Colorado. Lynn, thank you for being here today.
Hi, thank you, Kimberly. I'm going to share my PowerPoint here. So what is Centering Healthcare? Hi, everyone. Thank you so much for joining. Centering Healthcare Institute's mission is improving health, transforming care, and disrupting inequitable systems through the centering group model. We are a nonprofit organization. I didn't get that going, did I? Hold on, sorry. There we go. So Centering Healthcare Institute, and I will refer to us as CHI throughout the presentation. We're a nonprofit organization supporting over 570 clinical sites. We are an evidence-based model of group medical care, and our robust evidence base of more than 120 published studies show that birthing persons have healthier babies in centering groups, including a 33 to 47% reduced risk of preterm birth and a flattening of racial disparities. Pregnancy has been our flagship model starting back in the mid-90s, and it moved organically to parenting and other healthcare chronic conditions. So we have 3 models really. Centering is the billable primary care visit, typically 1.5 to 2 hour visits with a provider facilitator and a staff facilitator. We offer implementation support, training on group facilitation and group care, site approval, and licensing for model fidelity and quality assurance. So today I'm going to talk about guidance for adapting in-person groups to a virtual format. We found within 3 weeks of basically clinics shutting down in COVID in mid-March that by the beginning of April, we really needed to provide training requested from our sites on how would they take their in-person groups and keep them going somehow on a virtual format, because their patients were calling and saying, we still need to be in group. 3 components of care for centering groups: health assessment by the provider in the group space, interactive learning with staff and patients, and community building. And this was really important. If you look at these 3 core components, there was a lot of isolation during COVID, and this model helped people stay together, really deal with social determinants of health issues like transportation and childcare when everything went remote. So just some preparation tips for virtual groups. I could talk about this, by the way, for probably 2 or 3 hours. I'm just going to give you some big highlights, and then if we have time for questions, I'm glad to ask questions, or you can go to our virtual booth or virtual exhibit in the symposium and get more information. So really, you need to know your telehealth platform functions that you'll be using in your virtual groups. Some of these include the security issues, the security functions, one of which is the waiting room, breakout rooms, chat, polling, whiteboards. And we had for many years been using Zoom. So that was the platform that we trained from, but not the platform that everybody used. So knowing what your platform is for the clinic and is really important, so your staff understand what functions are available for the groups. And then planning ahead with participants. You need to know what, and they talked about this with the previous discussion with Nurse Family Partnership. You need to know what digital device your participants have. If they don't have any, then some of our clinics provided those devices to their patients who are going to be coming in virtually to the group, but also broadband access, which many of us found and across the country found that digital access, the broadband access was very limited in certain areas, especially rural areas. And so sites ended up contacting the broadband companies in their communities and asking for increased access for their patients. And many broadband companies were very responsive and helped patient communities get more access to virtual format. And then testing this virtual space out, both staff with their, the people who are going to be working in the group, but also the patients and the participants in the group visits. What did they have available? Come on in on an individual basis with a staff person in the clinic, and they test out what platform they have. They help the participants learn how to get on that group visit on a virtual space, so that when they come into the group, they spend less time working on just how do we do this, but rather what are we here for. And then for staff, planning your sessions is really critical ahead of time, working as a team with the other people who are going to be supporting the provider and the staff facilitators when they're in group. Figuring out your curriculum ahead of time, setting up whiteboards or there's a polling function in many of the platforms, and then activities that you're going to do to facilitate conversation around particular topics. And again, practicing. That's really important. It's pretty tough when you go in to your first session and you're struggling with the functions on the platform, and so are your participants. And then having tip backup. One of the things we found from sites, that sites have given us a lot of information about how they figured this all out and what worked best on the virtual space for staff and participants. But one of the things they said was having somebody who was really slick on the tech, on the platform that they were using, somebody who could help them with technical issues. For instance, we have someone on our presentation today who's the tech backup for this hour, and that's helped sites a lot. Okay, so clinical assessment. This is a huge issue around group visits on a virtual space. The provider, basically a private clinical assessment with the provider is done in two ways. It can be done in the waiting room. So you bring a patient in from the waiting room, you have their clinical assessment one-on-one with the participant and any support person they might have with them. And the rest of the participants stay in the waiting room, but they can't interact with each other. So a nicer function is if you have a breakout room function on your platform and everybody comes into the group space, and then the clinician can bring one participant and support, or patient and a support person who's coming with them into a private breakout room and do that 3 to 5 minute clinical assessment. Patients, and this was really sort of fascinating to watch clinics do this, they basically bought the medical equipment that the patients would need to do their vitals at home. So providing participants or pregnant patients with blood pressure cuff, weight machines, measuring tape for fundal height, stop tones for fetal heart rate, and would give those items out to the participants at a one-on-one visit at the clinic, train them on how to use them, and then send them home to do that at home before the group. Sometimes some patients would do that in the session with the clinician one-on-one, but typically it's best to do that before. The clinician would do a brief 3 to 5 minute clinical assessment, but most questions were best referred to the group for a facilitated discussion with other folks in the group. Okay. So creating a safe space is really sort of important in a virtual environment. Because participants are coming in from a home environment with children and family members often in the space as well, and a higher noise level. So participants are encouraged to find a private space in their house if possible, not always available. What happened when the one-on-one session at the clinic where the participants were given the vital equipment to take home, is they would often talk with participants about if you could have earbuds or if you could have earphones, then that blocks out what other people are saying in the group visits around confidentiality. The other thing that people can do is really, when in the first session, you can set some group guidelines, so an agreement between facilitators and participants. What does privacy mean to you? What needs to be in this space for you to feel like it's safe for our conversations together? But making confidentiality a part of the group guidelines, and this can be a verbal agreement for confidentiality, or a signed agreement that can be done one-on-one in the clinic at the first, pre-session, or it can be sent in the mail or email to patients depending on their access. It's always important to remember that sensitive conversations on a virtual space can happen in a group visit. And so ways to increase the feeling of privacy with the earbuds or the earphones, using a thumbs up or thumbs down function that you have that on some of the virtual platforms, or a patient can just do thumbs up or thumbs down if a question is asked. You can also use the chat function to share private information. So a provider or the staff facilitator might say, tell us if you're feeling safe at home. One of the things that they can do is put that in the chat individually to the medical assistant or the staff facilitator or the provider facilitator. But being conscious that sensitive conversations can happen and finding ways that participants feel there are ways to do that so they feel safe. Always good to center the group as you start sessions. So having a regular structure or flow to your sessions, similar to what you might have with in-person sessions if you were doing that prior to moving into a virtual space format. So maybe starting your pretty typical with centering groups. We start our circle up time with a soft chime, like that. It signals everyone that maybe clinical assessments have completed and we want everybody to circle up and have the interactive learning and share conversations with each other. You might also start with a mindfulness or meditation exercise or a fun opening to sort of increase engagement. And most of the activities that are done, not all, but most of the activities that are done in in-person groups can be adapted pretty well to a virtual format. Then reading the group. This is a little bit tougher on the virtual space. We need to be more intentional about reading the energy engagement of participants on the virtual space. There are lots of ways to check in with your virtual group. One of the things you can just do is ask everybody, how's everybody doing on this space? What's this feel like? And how can we make this better? Or you could say, could you put into the chat, how's everybody doing with the virtual space? And what's one thing you like about it and one thing you'd like to change about having a group in this space? You can also pin, there's a pin function on most virtual platforms. You can pin one person if you're really worried and you want to see them closer up. So it puts them as the main person on the screen. And that's one way of checking in with somebody you might be worried about. We also recommend that you change activities about every 20 minutes. It's hard to be in the virtual space for an hour and a half, possibly 2 hours, and not have some movement. And especially for pregnant persons, it can be really tough to sit for. Most of us who've had pregnancies know that after about 15, 20 minutes, you just have to move your body. And I'll talk about that on the next slide a little bit. So making it fun is one of the things we heard from our sites, that making it fun kept their participants engaged and it brought them back because people were feeling isolated at home. And how do we get to know other people? So sometimes using things like the breakout room at the beginning of your sessions to have 2 people meet, breakout rooms and only 2 people are in there, and you share just certain things about your life and what's happening right now. And then you might bring that back to the main group and you say what the other person told you and they say what you told them. And so you're sharing some of what you're going through, and but it's easier to do it with a small group. So using breakout rooms as small group activities helps people build community and get to know each other better. Movement is one of the things we heard from sites that was really fun and kept people engaged and wanting to come back. One site did a dance party where everybody got up and they had some music that was put on and every participant shared a different dance movement, and then the other people had to do that with them. Getting up and stretching in whatever way. Sometimes participants ask, would you like to share a stretching exercise you do? And then everybody else would join in. Walking meditation is a really nice one when you're in a stressful conversation or topic. you might just say, let's take a break and walk them through that type of meditation. So there's sort of a break and a relaxing of stress that might be happening in the group. Throwing a ball theatrically, I don't know if you can see this, but I have a really nice rubber ball, and I might say, so I would like everybody to share one thing that they've done that relieves a discomfort in the pregnancy. What's the discomfort and what are you doing to relieve that? And then I might say one thing, and then I'll say, so Maria, I'm going to toss this ball to you. You catch it, and then they theatrically throw a virtual ball to the next person that they choose in the circle. And the talking stick is a really lovely thing to use to manage conversations. You might have participants take a moment and find a talking stick where they are in their environment, a pencil, a wooden spoon, anything that they want to use as a talking stick. And you might say an example would be one way you're managing stress during the stay-at-home situation. And then after they share that, they pass that virtually, might say, so, you know, Judy, would you mind passing the stick to you? Your turn. Okay, so adapting some in-person activities. There are hundreds of these you can adapt to a virtual space. One really good example is chair yoga. So try a different chair yoga position. You can actually go on the internet and put in chair yoga, and it'll give you a great handout with all sorts of different chair yoga things. And then you adapt that to the group. Especially around pregnancy, you need to always say to people, you know, do what feels comfortable for you, and do it gently to start with. And then another way to use your environment, which we found really interesting. So everybody's in the group, pregnant person, support people, and you say, so why don't everybody get up and go to your kitchen and get a snack you have for today and bring it back, and let's talk about nutrition in pregnancy. And using that as a way of getting people up and moving around, but also talking about what are we eating in pregnancy, and you know, how's this helpful, and how's it help us manage stress if sometimes we eat emotionally. The other way that we had a site share with us, and it's also a centering activity that we've adapted to the virtual space, was childproofing. So everybody's in their environment. And would everybody just take a moment and go to and look around your room and identify one area that you might share how you've started the childproofing process, what you've done to childproof a particular area, or you need some suggestions about childproofing a particular area in your house. And you haven't been able to figure out, oh, how do I make this safe for my baby? And that's just nice because you're using the participant's environment. Participants can be trained before the first group session how to put a different background on their screen so they're not sharing their environment if they're not comfortable with that. So there's platforms, there are ways to do that. And then I already talked about small group breakout room activities are really lovely to build community slowly and changing who gets into those small group breakout rooms at each session. So you're building community that way. It's also really important that you establish prior to the first session some evaluation parameters for both staff and patients. What's working? What's a good feedback loop for our patients? And what's a good debriefing we can have with our staff team? I really recommend debriefing after your first session in particular. You know, what worked, what really went well with both tech and facilitation, and what changes would be helpful, and how can we make this better for both the staff team and the provider, and the patient participants and support people. And then adjusting those changes and implementing them before the next session. And, you know, people who've done this and moved to the virtual space last year, they made adjustments every session. It was a learning process for both staff and participants. But it was fun. They made it fun, and the patients found it really rewarding because they didn't feel as isolated. So there are lots and lots of ways of facilitating virtual groups. These are just some key facilitation tips to provide a framework for your starting the exploration into moving in-person groups to a virtual format. We found that some sites were starting to go back in person, and then with the Delta issues that have come up, they are moving back to a virtual space. Some people never left the virtual space, but they're having both in-person and virtual groups, because the virtual groups are really dealing with social determinants of health for patients who weren't getting in before the pandemic, specifically in rural areas and inner city areas where folks didn't feel very safe coming to the clinic. And this is just a really nice photo that we took. This is an advanced facilitation training that two of us did with a provider facilitators and staff facilitators across the country who wanted some advanced skills around facilitation in groups. And we did this on the virtual space, which was great because we could demonstrate for them how they would use the virtual space to do a group session with their participants. But it is something, you know, you can have your group participants and your staff folks take and share with each other. Okay. Here are some centering resources I put together. If you would like more information about centering group care, these are some resources, and this slideshow will be shared with everybody. I don't know if we have time for questions. If we do, I can take some questions.
We do have time for questions.
Okay, I'm gonna stop the. Okay, that went really fast. Okay. So people can come in, or you can put it in the chat.
Do you have any questions for Lynn today?
All right. Well, if you have questions, you want to know more about centering and Centering Healthcare Institute, please go to our virtual platform, our virtual space in the symposium, and there's lots more information there.
Awesome. Well, thank you all for taking the time to join us today during our breakout sessions. We look forward to your future participation tomorrow. Have a great day.
Everybody. Pia raised her hand.
Pia?
Sorry about that. I actually did have one question. I'm sorry. Can you hear me okay?
Yes, I can.
I don't quite know how to articulate it, but I guess it would be for both presenters, because it's not lost on me that many folks have transportation issues. And so that is a real barrier with them getting, you know, to their healthcare appointments, engaging with their nurse, or engaging in centering. And so, you know, one positive thing, I guess, that came out of this is that we were able to take away that barrier. So I guess I'm curious from both of your perspectives, if this improved engagement because they did not have that barrier anymore. And then I guess also, how do you think we might continue to capitalize on this moving forward, or what should we be thinking about as we move forward with how we can engage folks to ensure that, you know, that transportation is no longer going to be a barrier for their access? I hope that makes sense. I know that's not well articulated.
No, that's fine. I think, Pia, one of the things that was interesting to hear from sites was their worry that the virtual space would not be a billable visit after clinics opened again. And I think across the country, there are states that are working with Medicaid and other payer sources to figure out a way to still have that available, because they found that that patients in the rural area and inner city were coming to the virtual space where they were not coming in person beforehand. So some of our sites talked about, so they'll have an in-person group, but then the folks who can't come in because of either safety or lack of transportation, for instance, in Appalachia, you don't have a car, you can't get anywhere. And because there's no buses, there's no transportation for the community. So unless you know somebody who has a car, you're sort of out of luck. So clinics were devising a system where they had so many people in person, and then the other part of the group was virtual, bringing them in on a large screen, or looking for, a cohort of people who would just be virtual. It's tricky doing the in-person and virtual together. Some sites are really good at that, depending on their tech savvy and their training with patients. So lots of different innovative ways people are trying to adapt to this so that they can keep engagement for folks who are really struggling with social determinants of health around transportation, but also daycare. Daycare is pretty expensive. So how can I come in when I can't bring my children because of the COVID issues? Yeah, so that's kind of the ways clinics have been doing.
That's helpful. Thank you.
Sure.
So PIA for Nurse Family Partnership, we're a home visitation program model. So we go to the families and meet them at their home or a place that's designated. But that's not to say that they don't have transportation barriers to other services that they need, like going to the physician or going to a centering class, because you can be an NFP and still be in centering. So I love that synergy. So transportation has been, and I think will continue to be an issue, especially for rural sites. And the pandemic allowed families to be able to get services in their home in a different way than they were accustomed to getting it.
Okay. Thank you so much to both of you.
Awesome. Thank you all for joining. Bye.
Thanks,
Bye.
Kimberly and everyone else.
Thank you all.